Hi, everybody. Hi, everybody, and good evening. Um, for those of you that don't know me, I am Dr. Verdiales from the Atlanta office. And I wanted to say hi. It's been kind of a crazy week for me. I've been moving, and oh my goodness, it's crazy the amount of junk you can gather through the years. Um, but here we are, another day. I know the setup is a little bit more informal, but we'll have some interesting chats tonight and have some fun doing it. All right. So I normally try to pick a subject or an interesting case that had arise during the last week or so. And today I would like to talk about um, how to overcome some interesting challenges. So today I'll talk about a patient that I had surgery last week, and she has multiple issues. One, she has low ovarian reserve. She is 42 years old with an AMH of 0.24. And for those of you that know what that means, it is low. I mean, it's not impossible to use her own eggs, but it is low. However, she does have a few other challenges that we were unaware of until laparoscopy last week. In the past, she had 3 IVF cycles at a different clinic. The first two resulted in no eggs that would fertilize, and then the last one actually resulted in one embryo that didn't make it to day 3. So she comes to us with that scenario. She did complain of, occasional pain with menses, but nothing very dramatic. Um, we started working with her in terms of the Omnitrope and all the supplements that I tell you about. So, for example, a very good prenatal vitamin. There's several out there that are food-based and clean. One of my favorite, for those of you that have heard me before, is Garden of Life. It's easily accessible. You can order it online or find it in your health food store. There's Nutritional Frontier, that one we have in the office. There's one called Complete Research, also food-based, really good company as well. So good prenatal, make sure that you take extra vitamin D. Everybody across the board is deficient. So even if you're slightly deficient, I like to see that vitamin D above 50. I recommend to take at least 2,000 units of D3 on top of whatever you're taking. Make sure that your prenatal has folate, okay, instead of folic acid, and that it has at least 800 micrograms. Most prenatals do, but just make sure of those things. If you're dealing with low reserve, um, there's the CoQ10 or ubiquinol, it's active form. I know that you've heard out there about the DHEA. However, DHEA is actually a testosterone, and too much of a good thing in the hormone world is a bad thing. So you want to make sure that you are deficient before you start loading on DHEA. Otherwise, you're going to end up with a beard and bald. All right. So those are a few things. There's glandular therapy. I use a company called Standard Process, and from those of you that have heard me, I've talked about the endocrine pack. It's just easy. It has currant seed oil, which is a prostaglandin precursor, the omega-3 as a tuna oil. It has a food concentrate, and then the glandular therapy. There's a few companies that are also reputable. I like one called Ancestral Supplements. They have a male formula that's very good. It's called Male Optimization. However, they don't have, as of now, a female formula. So I use Standard Process instead. But going back to my patient, 42-year-old with decreased reserve and a few other challenges, we started working on trying to bring her reserve up. She had heard about the ovarian PRP, so wanted to try it. So we did have one PRP at time of saline. We did notice that, or what seemed to be an open left tube at the time of the saline, and the PRP was done at that time. About a week after the saline and the PRP, she started complaining of, you know, lower left-sided pain with that progressively worsened. And we did an ultrasound and found that she had a complex cyst on that side, and thus that was the reason originally for her surgery. We were thinking of endometriosis, and that's exactly what we found. We found a stage 4 endometriosis, and a very unusual finding was that she had an endometriosis mass that was actually protruding through the vagina. And my suspicion was that because she had had 3 previous retrievals, and when somebody has endometriosis as an underlying condition, you can spread it through surgical sites. And the area where the endometriosis mass was exactly in that posterior vagina where the needle for the retrieval goes through. And her previous REIs, they were not suspicious of endometriosis, even though, based on her history of having very poor quality eggs and embryos that did not survive, it all makes sense. So we found that she did have endometriosis on that left ovary. The right tube was blocked, and she had a lot of adhesions in addition to that unusual mass in the back of the uterus. So what to do in that case? That's a pretty unusual case, and that's the reason I'm sharing it with you, because I think it's more common than what we like to believe. I have seen endometriosis in C-section scars. I have seen endometriosis on laparoscopy scars, again, because it's an open wound and the pathology or the problem is there, and it kind of gets spread through a surgical site. So we're doing antibiotics with her. We did clean her pelvis. There was the discussion of donor eggs, even though that she's not quite ready to make that leap, but because of how her endometriosis had spread, due to prior retrievals, and she is 42 with a decreasing AMH, I think that her easiest and safest way of getting that miracle rainbow baby would be with donor eggs, or at least the combos, the combo package. And for those of you that don't know what the combo package is, it's like one of my favorite CNY programs, because emotionally, it is very hard for a woman to transition, to make that decision that she is ready to do donor eggs. And the combo package allows that emotional cushion of being able to buy donor eggs while you're cycling. And then if you get 1 or 2 embryos with your eggs, and then you get 4 or 5, embryos with donor eggs, then that allows you to have choices, and you can transfer one of each, or you can start with yours and then do the eggs from the donor. Or if you don't want to know, you don't need to know, and then you just kind of let it in God's hands, see what embryo he plants. So it's definitely one of my favorite programs because it allows for that emotional cushion to make that transition in a more safe, psychologically safe environment, without necessarily having the emotional burden of having a failed retrieval because of low reserve, or ending with like only 1 embryo to transfer. it gives you choices. So I wanted to bring her up because, again, it was a very unusual scenario of having endometriosis at retrieval site. You could actually see it through the vagina, and I had not initially noticed because it's a very different exam when somebody's under anesthesia and the tissues relax, and I have a better view of things. So I was able to really visualize it while she was asleep, but she had endometriosis scarring right underneath the cervix, which is the area of retrieval. All right, well, as usual, let's go into some of the questions that you might have, either related to endometriosis, low reserve, or anything that's pertinent to you. And for those of you that are joining us at this time, welcome to our discussion. We do every Tuesday evenings, 9 p.m. From 9 to 9:30, and then in Spanish on Thursdays at 9 to 9:30 as well. And I'm Dr. V from Atlanta. I know that Dr. Kills was up a little earlier. He's doing 8 p.m.s every day, and then his fireside chats at 10 in the morning on Sundays. All right. Hello, hello, hello. Thank you for joining, Michelle. She's one of our lovely Atlanta patients. Oh, great. I am glad, Miss Candice, that you liked our facility. I want you all to understand that from Dr. Kills down, we love what we do. We want to join you and walk with you through this journey. And we are humans. So unfortunately, we're not perfect. We might make some mistakes, or maybe the phone rings, or there might be a delay answering, but it's not because we don't care. We care very much, and you can use Dr. Kills as an example. He is allowing a lot of families to expand, irrespectively of financial situations, health situations, sexual orientation. We embrace everyone and anyone in this journey. And some of you know that we get what nobody else wants, that has either some medical issues that could be challenging their fertility journey or their health overall. But we welcome you. We want you to feel loved and welcomed and cared for, and you matter, okay? We all do. And your dreams matter. So just keep dreaming, okay? Very important. The worst dream is the one that is not fought for. Hello, hello, hello for everybody. Hello. Hello, hello. How do I feel about elderberry? I love elderberry. Elderberry is very good for immune support, especially upper respiratory. So these days, with the upper respiratory crisis that we are kind of living, elderberry is a great thing to have around. Okay, it's also a great anti-inflammatory. Awesome. So Miss Jessica is having her second IUI tomorrow, and she had an appointment for Reiki. Oh, I love energy work. I am a Reiki master, and for those of you that that have worked with me in that realm, I tend to do a lot more of that type of work with cancer patients. But I have done, visualization exercises and some energy work on some of the fertility patients as well. I think it's huge. Anything that will move you forward, it's a great thing to do. And we are mind, body, soul, so any little bit counts. So we'll go for it. Hello, hello, Taya. I miss you. It's crazy. Fertility patients feel a little bit like obstetrical patients. I haven't personally delivered babies since 2012, but after seeing, the obstetrical patient the entire pregnancy, and towards the end is every week, and then they deliver and they go away, it's kind of bittersweet because you miss them. So it's kind of like that with you guys. We see you and we see you, and we see your beautiful faces, and then you get pregnant, which is awesome. That's what we're here for. But then you graduate or you take breaks and you come back, but you are always loved. Okay. Wondering if I will be getting into town the day before retrieval and hoping for a fresh transfer. Will it still be good to do PRP and ACG wash, or is one time only not really enough? So, with the PRP, it is a cumulative. Okay, so even if you don't get pregnant on that cycle, it's actually going to help for the future cycles. I like to do, when we're doing multiple washes, I like to do them serially. I like to start with PRP the earliest. If you're coming the day before retrieval, then do PRP, and then you can do the ACG wash the morning of. Um, so, you know, I think it's great. And then by the time, if you're able to do that fresh transfer, that gives you almost a week, because it's 3 to 5 days after retrieval that you can put that embryo back in. So then it's still great. I think that it will help you on that cycle, and hopefully that's going to be the tilting point. And if you don't get pregnant on your next retrieval, then it definitely will help you moving forward. PRP is a cumulative. For those of you that heard me talk about my Brazilian partner and friend in this journey, she did 5. Um, so it accumulates. Doesn't matter where you use the PRP. I mean, PRP is used in essentially every part of the body. I have a patient, a beautiful, beautiful patient, and we've been working for a year and a half, 18 months. And the reason I use PRP on her is for nerve injury. She comes every month for her PRP. She had a shot wound to the arm that damaged her brachial plexus on the left arm and caused atrophy and loss of use of the lower limb and hand. So we've been working on trying to help her regenerate the muscles, the nerves, therefore getting more functionality, and also for pain management, because injured nerves, for those of you that suffer from this issue, are constantly firing and causing chronic pain. And in all those areas, she has improved greatly. She does do physical therapy 2 to 3 times a week, which is great, because then as we are helping her with her muscles and her nerve injuries, it helps, regenerate some of the function, but also her pain has decreased. So again, it doesn't really matter where you use it. You are harvesting your own healing proteins and putting them where you need them. So there's a process of healing. Of course, there's a little bit of wear and tear, but healing, wear and tear, and it helps long term. All right. What lab values do you guys look for to determine if a fresh transfer can occur instead of a frozen? There's a few things that have to happen, especially the day of retrieval. One, we are looking for a trilaminar endometrium. So at time of retrieval, trilaminar endometrium of at least 7 millimeters in size. Okay. Why is that important? Because that means that it's a true day 0 and you have not ovulated. Okay. Then that is matched to the progesterone on the day of retrieval that needs to be less than 1.4, 1.2. Okay. So between that and that is very important. Also, we look for the estrogen level. If your estrogen level is extremely high, let's say you harvest 20 eggs and your estrogen level is close to 3,000, okay, really more than 2,500, then the chances of hyperstimulation syndrome, ovarian hyperstimulation syndrome is very, very high, will be dangerous to do a transfer at that time. So we look at all those values together, and then based on that, we, give you a green light or not. If I have anxiety attacks, how many embryos do you recommend for transfer? I recommend one regardless of whatever the situation is. And the reason being that these are not spontaneous twin pregnancies, okay? So it's a matter of allowing that one embryo the best chance possible of survival. If you put more than one, you are actually putting two to compete for the food and space of one. I know that in certain occasions, and each case is different, there are arguments in favor of more than one. Ultimately, it's going to be your decision. The rules of the game or the suggested practice guidelines says that under 35, 1 over 35, up to 2, if the embryos are normally PGT tested normal, then 1 regardless. But ultimately, the transferring doctor tends to honor your desires. Okay. Dual cycle. You need to be a little bit more specific about what, I don't quite understand what you're trying to say. A dual cycle is when you do stimulation retrieval and then go into stimulation retrieval back to back. That works better with, AMH of higher than 1. In certain occasions, we may do it for low AMH, but what I have seen in my experience so far is that one of the two cycles is going to be crappy. Sometimes I've seen where if the first cycle is not too great, then the second cycle in a low AMH might have a better response. But on a low AMH, low ovarian reserve, a dual cycle is not really that successful on both rounds. So my IUI failed, and I would like to schedule a laparoscopy because I don't know if I have endometriosis. Absolutely. Like I was sharing with you at the beginning of this this talk, endometriosis can be kind of a silent problem. Like my patient, my 42-year-old patient with the AMH of 0.24, where she had already gone through 3 IVF cycles and with some symptoms, but not, honestly, I was surprised of how her pelvis was. It was in really bad shape. And I wish that she had undergone that laparoscopy a lot sooner. She's been doing IVF since 2014. And now we are figuring out why she's failing. So I'm all about checking things before you go through treatment. So yes, absolutely, go ahead and let's schedule that laparoscopy. Is it okay to dye your hair during IVF? Yes, it is okay to dye your hair during IVF. It is not recommended to dye your hair while you're pregnant, especially first trimester. First trimester is crucial. It is when the baby is formed. So any insults in the first 3 months of pregnancy are permanent damage. Okay, so I know that when I was pregnant, I took it like a woman, and I was sick like a dog. I used to lose a lot of weight, but I've seen in my short, span as a doctor, or shortish at this point, that drugs, go up in glory and fall out of glory very quickly. When I was a resident, they used to use Sofran like it was candy for nausea in pregnancy, just to figure out a few years afterwards, oops, it causes birth defects. Or some antidepressants, that I think it's Paxil. It was, it's okay to take, and next thing you know, it's like, it causes heart defects, and that has happened in medicine many times. I do not encourage any unnecessary medication. And again, this is risk and benefits. There's situations where you need to take your meds, but if you can minimize the toxins that you expose your fetus to, is the best. Can you take CoQ10 after transfer? Absolutely. CoQ10 is essential for muscle, heart, endocrine function. All right. Neupogen wash and ACG boosters, or ACG wash with Neupogen injections. And what are my thoughts on BMI and transfer outcomes? Okay, so Neupogen wash, I like those. It works really good for lining issues. The ACG boosters, I don't have a lot of experience. I know that, I see them ordered. I don't have enough good or bad. To me, it's kind of like, oh, okay. I mean, it's not gonna hurt. I like ACG washes. Neupogen injections, I prefer the wash over the injections. But depending on what you're trying to accomplish, if you have a underlying immune issues, then Neupogen could be that tilting factor in your favor. And then with BMI, the problem is that BMI, even though we don't like to talk about it, BMI is a representation of your overall health. So even though a lot of women with high BMIs have no problems getting pregnant, the higher the BMI, the more issues in terms of transfer, complications during pregnancy, balancing hormones, and things like that. However, if you start with a high BMI, and we have seen BMIs up to like 55, which is pretty high, even if you start on a very high BMI and you start making the changes, the lifestyle changes, and there's a progress towards lowering your weight, even if it's like 5 to 10 pounds, could make a huge difference on the health of your endocrine system. So it depends, even though BMI has an impact and it could be a representation of your overall health, the correction of those behaviors, even if it comes out to be losing a tiny bit of weight, could be the tilting factor in your favor. I've seen it over and over again. I work with people, I've worked for years with fertility patients, especially PCO patients. And when they start losing the weight, I put them on the diet and help them with appetite suppressants or whatever's needed. They start losing the weight, and it doesn't need to be a lot, 5, 10, 15 pounds, and sometimes they get pregnant spontaneously. Right. Hello. Will the Atlanta office offer IVF in the future? That is in the plans. We're early in the development stages. There has to be a lot of growth before we can get there, but we are aiming at early 2021, okay? We are hiring like crazy, allowing the new staff to get adapted. The fertility world and the IVF world is highly specialized, so even if we get wonderful nurses with women's health backgrounds or nurse practitioners with women's health background, if they don't have any IVF, previous knowledge, we have to train them. So allow them to grow into the position before we can just start hiring people, because we want to do this in a safe way in order to serve you adequately. Okay. Hello from Ohio. What causes endometriosis? Mine was not diagnosed until I was 34. I was put on the pill as a teenager to control heavy, painful periods. I've never been pregnant. So endometriosis, it's actually an immune deficiency. It is an inflammatory process, and what happens, it is associated with the spleen NK cells. They're slightly defective, and they are not able to clear out, um, sorry about that, the endometrial cells that might be spilled into the pelvis. Some of the theories about it is that, during menses, there's retrograde menstruation through the tubes. There could be migrations through the vessels, since the vessels inside the uterus are pretty open. So there might be some migration that way. Regardless, essentially, this is an abnormal implant. It is the wrong cells in the wrong place, and the immune system is not being efficient about doing the quality control and the cleaning. Endometriosis is, you're pretty much born with that predisposition, and it tends to show up during the teenage years because that's when you start having your menses, and the implants are related to the estrogen and the process of menstruation and ovulation. So even though you were diagnosed at 34, you probably had it all your life. It was just never diagnosed. Endometriosis is a diagnosis of pathology, meaning somebody has to go into your belly through laparoscope, take a biopsy, and the pathologist gives you the diagnosis. You could have a suspicion of it, even if it's a very high suspicion. The treatment is not going to change much, but unless you have a pathology diagnosis, you cannot say you have endometriosis. Hmm. Yes, yes, Vicky. Um, I I think that um, this process is so personal, and being being a woman, I get you. Um, and I am an older woman, and I mean, God has blessed me with children, but I put myself in your shoes, and honestly, I had a similar experience, with, you know being infertile. Um, Even though, I mean, I have my children, I have been married 3 times, and my third husband didn't have any children, and we were married older. I was 40 when I married him, and I had previously tied my tubes and burned my uterus. So it's like a lot of for challenges. And when the question of children came up, honestly, I was not even aware that CNY existed. So I feel very blessed to be part of this process. But, at that point in my life, IVF was 20 grand, and I felt I was going to be irresponsible to spend that money on IVF when I had already other children that I needed to take care of, as a single mom, because, they were not um, children of my third husband. But through that process, I had to face some of the challenges that you guys face. He's like, what's next? What if my uterus doesn't heal? What if, the eggs? And I think that you have to be emotionally and psychologically ready to go through the steps. And you're ready at a point, but it's personal. You have to be ready. You have to be ready to go through the next step. Just like whether you choose a tubal reversal versus IVF, whether you choose donor eggs versus your own, whether you choose adoption at one point, whether you use a surrogate woman to carry your children. These are all, very emotionally heavy driven and psychological decisions, and you have to feel in your heart you're ready for that step. Otherwise, it's that little thing in the back of your head just torturing the shit out of you. So I am very, very respectful of this journey. And like I tell, my Atlanta patients, I will walk the walk until you're ready to do whatever. Donor eggs are always going to be a choice. Why? Because as you progress in your journey, if you're 45, 46, 48, whatever your age is, and you decide to jump into donor eggs, well, the donor is going to be 30. It doesn't matter if you're 45, 46, or whatever your age is, but you have to be ready for that decision in your heart, in your mind, and you have to feel, that you have exhausted your other choices and that you're ready to move forward. So, yes, you have to be ready, and it's extremely important to make that decision. And I understand that in certain places it is not addressed um, in the right environment, in the right context. And I am sorry that you had that experience. But hey, you're here, so good vibes for you. All right, so I'll go through a few more. Our time is coming to an end. Um, 46 years old in menopause. Blood work done in November. Endometriosis, fibroids, and polyp removed 2 years ago. Donor eggs, or can we try blood work and see if we can use my own eggs? Um, so we would have to work through it. Okay. Um, I have seen miracles. Miracles happen every day. You have to believe. You have to, be willing to, do the incredible. Drastic results require drastic measures. So from the diet to meditation to yoga to Mayan massage, fertility massage, to the supplements, the PRP, the Omnitrope, you have to be ready to train like an athlete going to the Olympics. And I have seen those FSH drop to normal range, and I have seen um, AMH stabilizer go up, and I have seen people make embryos. Actually, I was discussing that earlier today with a beautiful patient from Las Vegas. She is in menopause. Her AMH is 0.08, and she has embarked in this journey. And, you know, her last retrieval did not make a lot of eggs, but she got one embryo that she has chosen. She's trying to see how many embryos she can bank, but she banked an embryo. That in itself is a miracle. So miracles happen every day. You just have to believe and be willing to fight for them. Okay. Inositol stops my cycle. Alrighty, so you can just go ahead and get some labs, see where you are, or you can do Provera. Either way, it will bring some information to the table. Okay. Right. All right. I see that you have a lot of questions. All right. So I must let you go tonight, but I will be back on Tuesday. We can definitely have a more extensive discussion. For those of you that want to reach me, I do have a Facebook page. It's Maribel Verdiales. Let me see if I can write it down for you. You can definitely reach out to me. So that's my name. I have a Facebook page. You can reach out through Messenger, give me your information, and I will forward to the appropriate staff so we can either accommodate you and get you in for a phone consult or whatever works for you. And if you have a quick question that you want to send me, I will definitely be answering probably tomorrow morning. May you all be blessed. Remember, miracles happen every day. There's no reason why your miracle is not in the making. You just have to believe and be willing to, just keep fighting. The dreams that are the most silly dreams are the ones that you are not willing to fight for. So, again, may you all be blessed, and I will see you next Tuesday at 9. Bye bye.